Start Enhance project, our goal is to decrease the disparities for the Black birthing community and also decrease the infant mortality rate. And so I'm glad you all are here and excited to hear what Miss Dr. Duplessis is going to share with us today. And so I'll go ahead and pass the mic over to Miss Natasha.
Thank you so much, Jessica. Hello, everyone. My name is Natasha Falgren, and I'm the consortium manager for the Healthy Start Enhance San Bernardino project. The consortium is focused on decreasing infant mortality rates within San Bernardino County by bringing together community partners and community members to create actionable plans to be implemented within the county. So I just want to start off with a few housekeeping items. Just want to let everyone know that the webinar is being recorded, and the recording will be available to all registrants following the webinar. Please stay muted throughout the webinar, and also hold all questions to the end, because at the end there will be 15 minutes where Dr. Duplessis and her team will be able to address all of your questions. So it is my pleasure to introduce Dr. Duplessis. She joined the California Maternal Quality Care Collaborative, also known as CMQCC team, in 2022 to lead community engagement and partnership development. She has an extensive public health background addressing health disparities, collaborating with community partners, and implementing interventions, as well as prevention strategies that empower and improve outcomes among marginalized populations. In her current role, she organizes and implements outreach activities in partnership with local, regional, state, and national agencies to reduce maternal and infant morbidity and mortality. Dr. Duplessis earned a bachelor's degree in sociology with a minor in African American studies from UC Berkeley, and a master of public health and behavioral science and health education, from the Rollins School of Public Health at Emory University in Atlanta, Georgia. She then pursued a doctor of public health and community health sciences with a minor in epidemiology at the UCLA Fielding School of Public Health. Dr. Duplessis is a breast cancer survivor who has triumphed over adversity, bringing a unique perspective to her work in community health and maternal health. Her personal experiences have fueled her passion for advocating for health and well-being, especially in underserved communities. She is dedicated to making a positive impact and sharing her knowledge to support others in their health journeys. So we look forward to her presentation. I turn it over to you, Dr. Duplessis.
Thank you so much, Natasha, and thank you, Jessica. Thanks so much for having me today. So Teams, I'm fairly new with Teams, so give me some grace here while I try to share my screen. Hey, Lisa. Okay, can you guys see my screen? You can see everything? Okay, wonderful. All right, so good afternoon. Thank you so much for having me, and thank you for hanging out with me today to hear about this important topic. So today is World Preeclampsia Awareness Day, and I'm excited to talk about the LDA campaign that I've been leading at CMQCC for the past 2 years to reduce preeclampsia and related preterm birth. So this day aims to increase awareness of this dangerous pregnancy complication that can be life-threatening for moms and babies. And the theme for World Preeclampsia Day 2024 is Predict, Prevent, and Prevail. So we try really hard at CMQCC to use inclusive language, acknowledging that all people who have babies do not identify as mothers. So you will hear me say birthing people, mother, she, them, her. I like to mix it up so that I can honor everyone who is having this amazing experience. And then family can be broadly defined. It can encompass partners, husbands, wives, support persons, loved ones. It really is any person or persons that the pregnant or postpartum patient gets support from. So I have no financial disclosure or conflicts of interest with the presented material in this presentation. And this slide set is considered an educational resource. And so just a quick disclaimer, please note that this presentation is focused on the importance of community and community engagement. It is not a heavy clinical presentation. There will be some clinical pieces, I'm really here to talk about discussing risk respectfully and the importance of folks at hospitals, clinics, and communities working together and not in silos to help eliminate disparities in healthcare. So I'm sure most of you have heard of CMQCC, and as Natasha mentioned, it stands for the California Maternal Quality Care Collaborative. And the mission of CMQCC is to end preventable morbidity, mortality, and racial disparities in maternity care. And we've been around for a while. We are celebrating 17 years. And we at CMQCC are committed to evidence-based and data-driven quality improvement. CMQCC has a formula that combines outreach and stakeholder wisdom with research and data into quality improvement toolkits to address pressing threats to maternal health. So the objectives for today: review risk factors, identifying who meets the low-dose aspirin criteria for preeclampsia prevention, discuss best practices for respectful, compassionate discussions with patients, including scripts and tools for tackling these difficult conversations and addressing structural racism as a mediator of health outcomes. We will review some tips for essential patient education, and then finally discuss the LDA campaign and the importance of community-based QI implementation. So what are a few things that Serena Williams, Tori Bowie, and Allison Felix have in common? So as we can all see, they are all women of color. They are all Black women, and they all have a lot of resources. So they are Olympian athletes. And that being said, they are extremely well aware of their body and its function. They know when something is right and when they're feeling 100%, and they know when something is wrong. They've all experienced traumatic births. Serena Williams has shared her near-fatal birthing story with her first daughter. She had to have an emergency C-section after her heart rate dropped dramatically during her contractions. And after giving birth, she alerted a nurse to what she felt was happening in her body and asked for a CT scan and a blood thinner. But the nurse suggested that pain medication had perhaps left Miss Williams confused. When the ultrasound revealed nothing, she underwent a CT scan, which proved that she had a pulmonary embolism and showed several small blood clots had traveled to her lungs. Now, our hearts go out to the family of Olympian Tori Bowie, who lost her life last year due to pregnancy complications. The track star was 8 months pregnant and in labor alone at the time of her death, according to an autopsy report shared by the New York Times. The autopsy listed respiratory distress and eclampsia as possible complication. And Allison Felix never imagined that she would experience a serious problem during her pregnancy. Yet with 2 months to go until her due date, she was diagnosed with severe preeclampsia and had to be admitted immediately to the hospital, resulting in an emergency C-section and the premature birth of her daughter, who spent a month in the NICU. So all of these women have access to quality care. So it just goes to show that no matter your education, no matter your income, Black women are 3 to 4 times more likely to die from pregnancy-related causes. And eclampsia occurs after preeclampsia, and this is where community can bridge the gap. And as you can see here at the top of the slide, it says racism alone is not killing Black mothers. Inaction is. So we really need to wake up and get to action. It is time, and it has been time. So what is preeclampsia? It's new hypertension in pregnancy with direct effects on both the mother and fetus. Often there is protein in the urine and may lead to seizures and severe injuries to the kidneys, liver, heart, and brain. The fetus is sometimes delivered preterm with possible long-term complications, undersized and admitted to the NICU, and in severe cases, even stillborn. So a little level setting specifically about California and how patients are dying in this perinatal period. So for the pink one you see here on the screen, hypertensive disorders of pregnancy. So severe chronic hypertension, preeclampsia with severe features, it might be eclampsia, anything that's on that hypertensive spectrum, those are all grouped together. So we made some progress in this area, partially because of the collaborative work that's being done across the state of California with the help of CMQCC reviewing data, working in teams, exchanging best practices. But it is still a major cause of maternal death in all of these groups that you see here, but particularly for Black birthing people. So this slide makes my colleague, Dr. Amanda Williams, and I pretty sick to our stomach every time we see it, because the scale on this slide for Black birthing people, you can see here, says 1 to 3. So the size of the bars is misleading, but they had to fit it on one page. So the people that look like me, the death is so much that it doesn't even fit on the page. It doesn't even fit on this slide. Now that's pretty deep. So as you see here for Black birthing people, it says 5.6 for the hypertensive disorders of pregnancy. And look at those numbers look at that number compared to the others. There's like a 1.2 and a 0.6. So that's a huge difference. We really, really need to take this seriously. So why low dose aspirin? Why has the March of Dimes and CMQCC committed so much time and so much energy and resources to promoting aspirin in our communities, and why we are asking you to help promote low dose aspirin is because it is the only preventive measure that we know that has evidence to support it that can prevent preeclampsia. Low dose aspirin in pregnancy can support healthy placenta development, preventing changes that can lead to high blood pressure. And those taking low dose aspirin are more likely to deliver at full term and less likely to have preeclampsia. So let's go over a few facts. Hypertensive disorders of pregnancy complicate between 13 to 16% of all pregnancies nationally, while preeclampsia complicates 3 to 4% of pregnancies yearly, causing maternal and newborn morbidity and mortality. And so this is dependent on the populations that you are serving. And if you're working in a population that serves Black, identified, or advanced maternal age patients, these are some of the most high-risk groups. And if you're seeing a lot of those patients, you are going to see preeclampsia even more. So prophylactic LDA, 81 milligrams, for those who have screened at risk, reduces fetal growth restriction, preeclampsia, preterm birth, and perinatal death, and is the only intervention for the primary prevention of preeclampsia. The development of preeclampsia increases the risk of chronic hypertension and cardiovascular disease later in a birthing patient's and the offspring's life. LDA commenced between 12 and 16 weeks and taken daily through delivery for those who meet the criteria is still in need of wide implementation in a standardized fashion nationwide. And screening for preeclampsia risk provides the ability for early intervention, prevention, and closer monitoring during pregnancy when indicated. So this is confirmed by the United States Preventive Services Task Force, American College of OBGYN, and Society for Maternal Fetal Medicine. So all of these big bodies agree. And in 2021, they made a joint recommendation for daily prenatal LDA for birthing patients with any high-risk preeclampsia factor or more than one moderate risk factor. So a simple over-the-counter low-dose aspirin can reduce preeclampsia by 15%, preterm birth by 20%, fetal growth restriction by almost 20%, and perinatal mortality by more than 20%. So this translates to healthier moms and healthier babies. But these recommendations have been slow to become widely used. So multiple studies find that less than 25% of eligible women are offered or take low-dose aspirin. So are providers not prescribing it, or are patients just not taking it? Women with chronic hypertension are the highest utilizing group, but among them, only 50% take LDA. And then lastly, among Black pregnant people who are eligible, only 10% received low-dose aspirin. So medical information and prescribing are just not enough. There's just barriers to adoption, and this is multifactorial. So it could be information overload, confusion about preeclampsia, maybe difficulty obtaining prescription because your provider can prescribe it to you, or you can go to your local Walgreens or CVS or Target to pick it up. Difficulty with pill taking. There might be pregnancy fog or any other health or personal challenges. There might be fear of medication in pregnancy. There's lots of tales and concerns out there, and there could be reluctance to take a medication during pregnancy, let alone every single day. Perception of mixed messages among healthcare providers about the safety of aspirin, and then perception of stigma about certain risk categories like obesity. So some of these may resonate with your experience, and we know that implementation is hard. So some other reasons why low-dose aspirin has not been widely adopted. It could be something new, changing office workflow. The screening tool might be complicated and awkward to use. Maybe the tool is confusing for patients and non-clinical users. Providers not educated about the importance of aspirin. And then difficult discussions with patients, especially around race and low SES. I understand these conversations might be difficult. And, sometimes we only have a 10 or 15-minute appointment with our providers and with our patients. And then lastly, lack of trust in the medical system. So let's talk about risk. So clinicians should be bringing this up in the first prenatal care appointment with the goal of starting it in that 12 to 16 week period. Now, there has been some benefit that has been shown all the way up to starting up to 28 weeks. So even if someone is late to prenatal care, there is still an opportunity. So which patients? All patients should be screened, whether they are deemed or viewed as low or high risk. And then we want all prenatal care providers to know about this and be screening at the first prenatal care appointment, because many of these risk factors are demographic as opposed to clinical. So patients still may have multiple risk factors and be seeing a low risk provider. And some of these factors are Black race, first pregnancy, and low income. So who is at increased risk of preeclampsia and should be receiving low-dose aspirin? Let's look at some of the risk factors. So I know this is a busy slide, and I'll walk us through it. So let's look at the left side. These are the high-risk factors. So if you have any of these, the patient should be on low-dose aspirin. So there's preeclampsia in a previous pregnancy, chronic hypertension, multifetal pregnancy, so that's twins or more, diabetes, kidney disease, and autoimmune disease such as lupus. And on the right side, we have the moderate risk factors. And these are the factors that can increase your risk, but not as much as the high risk factors. If you have more than one, then the recommendation is for you to get started on low-dose aspirin. And you can see at the top, nulliparity, that's first baby, that's a lot of patients. And obesity defined as a BMI over 30, which is not that high. And then we have Black race. So let's be clear, this risk factor is exposure to systemic racism. People get lazy at times and people just want to say, oh, Black race is a risk factor. It's really important to note that there is nothing wrong with being Black. I personally love being Black. It's wonderful. But it also comes with a history that is full of environmental, social, and historical inequities, shaping health exposures, access to healthcare, and unequal distribution of resources. This is not about biological propensities. This is about the epigenetics that happen as a result of that history. And the same goes for lower income. Other moderate risk factors include personal history factors. So that's if the birthing person had a prior low birth weight baby, small for gestational age, or another previous adverse pregnancy outcome, or a pregnancy interval of more than 10 years, age over 35, some say over 40. And then lastly, pregnancy conceived by in vitro fertilization. So as you're looking at this list, think about how many of your patients would fit into these categories. And for Black race and lower income, some groups say that you can even consider low-dose aspirin if those are the only risk factors that you have. And given how safe aspirin is, they will make that recommendation. So when having compassionate discussions with patients about this, it is our responsibility to ensure that patients feel empowered, well-informed, and equipped to make the best decisions for themselves and for their baby. We really need to explain the risk factor screening process benefits. They can help identify those at higher risk for developing preeclampsia and provide an opportunity for prevention. And then reviewing and discussing. It's important to start these discussions early on in pregnancy because it might take an appointment or two for people to get the information that they need, to digest it all, and to get their questions answered. So all risk factors should be discussed with all patients. Explain each risk factor fully and assure that questions are encouraged and patients are able to verbalize that they understand what is being told to them. All right, so when you're talking about exposure to systemic racism as a risk factor, that is not a comfortable conversation to have, but it is needed and it is necessary. It is important to say the word racism and to help patients understand that this is nothing that they did and there is nothing genetically wrong with you or some genetic predisposition. It is about environmental, social, and historical inequities. Structural racism is recognized as a mediator of health outcomes and has impacted preeclampsia rates. This risk factor has been well established and studied. Acknowledging and discussing this factually and respectfully is the best practice. Non-Hispanic Black women are disproportionately affected by preeclampsia, along with being most likely to experience related complications. Now, the exact reasons for the increased risk of preeclampsia in Black patients in the United States is not fully understood, but it is believed to be due to toxic stress from a history of racism and discrimination in American healthcare and throughout history. So we're talking about decades of constant stress on the body, which we know worsens overall health outcomes. This is heightened during pregnancy, and I'm sure many of you have heard the concept of weathering. Constant wear and tear on a Black woman or birthing person's body, that's generational trauma, and lived experience becomes biology. So Professor Mahmoud Fatala was a wonderful OBGYN, and he has been remembered for this powerful statement. Women are not dying because of diseases we cannot treat. They are dying because societies have yet to decide their lives are worth living. So the March of Dimes and the Preeclampsia Foundation have looked at different factors to consider during your education with patients, and they found that less than half of pregnant patients know the signs and symptoms of preeclampsia. So ask about specific signs and symptoms rather than asking if there are any signs and symptoms your patient would like to report. So we need to make sure that patients, families, and their communities know and understand the signs and symptoms of preeclampsia because these are the people that they are connected to. So knowledge is power. Let's empower our patients. Patients have historically reported a lack of understanding about their preeclampsia. Knowing preeclampsia signs and symptoms is the first line of defense for early diagnosis and treatment. The disease process can progress rapidly. Patients understanding the signs and symptoms that require immediate reporting can save lives. Patients and their family and friends are often the first responders, so education really is power. Understanding how severe preeclampsia can be may improve reporting and treatment compliance. And then lastly, patient education improves clinical outcomes. So we just want to be as clear as possible. Someone may have a PhD, but they might not have a PhD in preeclampsia. So we want to simplify as much as possible. And we all need this, especially when it is not our area of expertise. So for written patient education, it should be between a 4th to 6th grade level, simple words and short sentences, only evidence-based information, and include pictures when able. For verbal, we must educate at the patient's knowledge level, assure that the patients understand by repeating back and giving time for the patient to talk about the topic, encouraging them to ask questions. And if providing instructions, have the patient or family or friend demonstrate back to you. And then provide sustainable resources. You can get those from the Preeclampsia Foundation at preeclampsia.org. And check out the mini CMQCC toolkits that we have at cmqcc.org. So let's talk about promoting low-dose aspirin in the community. So here we have a driver diagram that my team and I put together for this project. So essentially, a driver diagram is a visual display of what drives or contributes to the achievement of a project aim. So as you can see here, the aim, 80% of at-risk patients will utilize daily low-dose aspirin during pregnancy to at least 36 weeks of gestation. And on the right, you see the primary drivers. And in order to achieve this aim, we need to change provider practice, engage patients, engage community partners, and create a data collection system. Now, I know this is a very, very busy slide, and it is not meant to be overwhelming. I just want to show the extensive work that my colleagues and I have been doing and the different layers that are needed for implementation. So LDA for prevention of preeclampsia is proven science. But how do we improve use and adherence? Through implementation tools and collaborative learning. So as we see here, this is a deeper dive into our driver diagram, which you just saw, which we have used to organize implementation. So here in the middle, you can see we have secondary drivers, and on the right of that, with proposed ideas to help drive change, and how CMQCC really wants to create a learning and sharing collaborative. So this is a pretty cool slide about community-based QI implementation and the roles of influencers. So healthcare providers, social media, family members, churches, WIC, Black Infant Health, Healthy Start, all play a crucial role ensuring adherence to low-dose aspirin. Providers can educate patients about the importance of taking LDA as prescribed, monitor their progress, and address any concerns. Everyone that you see here on this slide can provide ongoing support to promote adherence throughout the pregnancy. And additionally, you can see at the bottom, pharmacists can also play a crucial role in counseling patients on proper use. So I'm a public health person, and I love conceptual models. So this is a community-centered approach to promoting low-dose aspirin adherence using a methodological approach to center and engage community. And I want to be clear that this does not include all populations and interventions within the scope of this project. This is simply the approach that we are taking for this project. So as you can see here, we have providers, communities, pharmacists, nurses, doulas, midwives, and birth workers. And under interventions, we have education, outreach, and data, which I'll get to shortly. And then all of this leads to establishing guidelines for a community-centered promotion of low-dose aspirin, which can then lead to scaling up of our initiative. So communities really are the next frontier and just so important. And so I'd like you to please take a look at this word cloud and see how your organization can show up or have an active role in advancing maternal health. CMQCC has a focus on hospital and clinic work, and now we are incorporating community. And we have finally landed on the right project to include community-based organizations, clinics, community, and patient voices. Uplifting community and patient voices and their birthing stories are so important. Community-based organizations, communities with lived experience can further inform the importance of QI. Communities and community-based organizations are so important to bring to the table when doing these types of interventions. So this is, I just wanted to put some pictures in there showing, that we are out there collaborating with community partners about the importance of this LDA initiative. We attended a couple of March of Dimes events, even a church event. And it's just really cool to be in these spaces to be able to listen and learn from community partners. So the Let's Do Aspirin campaign, let's get to it. So funding for this project is generously supported by the March of Dimes. So thank you to the March of Dimes. And the goal of this campaign is to reduce maternal and infant harms from preeclampsia by identifying birthing people at risk of preeclampsia early in gestation and encouraging the use of daily low-dose aspirin for the duration of the pregnancy. So what has CMQCC been doing with this campaign? We have been engaging with California, with pilot hospitals, community clinics, community-based organizations, and patients with lived experience. So the Let's Do Aspirin campaign, for the first cohort, we worked with 5 hospitals and their clinics. Loma Linda University Children's Hospital has 3 clinics. Riverside University Health System Medical Center with 7 clinics. UC San Diego with 3 clinics. Scripps Chula Vista, which is also in San Diego, with 3 clinics, and then Mercy San Juan up in Northern California and Sacramento with 3 clinics. And Kaiser Permanente Northern California is also doing an LDA initiative. So the key elements of this campaign are to make it easier for providers to screen and prescribe LDA, increase patient awareness of the benefits and lack of risk for LDA, increase community awareness of the benefits of LDA to support women and birthing people in their LDA decisions, educational outreach on the benefits of low-dose aspirin. So implementation in terms of our hospital and clinic outreach. So we put together some patient and provider surveys, and these surveys are used to identify the barriers and facilitators to aspirin uptake, like patient education, access, prescribing practices, and they're in English and Spanish. And here you can see our patient flyer, and it has a QR code, which you can scan to get to the survey. It's a quick survey, takes about 10 minutes. It also shows here eligibility criteria to be able to participate. And then once you're done, you receive, I believe it's a $15 gift card. So QI collaborative meetings. We have these monthly, and they're made up of hospital site leads, clinic champions, community-based organizations surrounding those pilot hospitals that we're working with, and then our patient advisory committee. And then data regarding low-dose aspirin is gathered in the hospital during the med reconciliation process, not in the clinics. And there is no extra work to get this information into the Maternal Data Center. And the data includes, was the patient on low-dose aspirin? And if so, what was the dose? When did they start taking low-dose aspirin? When did they stop? And then where did they receive their prenatal care? So LDA implementation in terms of patient and community outreach, we have our patient education materials, which are also in English and Spanish, and we will do more languages as we scale up. We continue to identify and fine-tune community messaging and outreach materials to educate women about the role of low-dose aspirin during pregnancy. And here you can see we have our poster and our information sheet. The patient education materials feature a QR code that takes patients back to the March of Dimes website to learn more about low-dose aspirin and preeclampsia. And we also encourage patients to talk to their healthcare providers about aspirin, as well as highlighting the importance of keeping your baby safe, which is a priority for women and birthing people. So for videos, we wanted to produce educational videos showing the different provider and patient interaction scenarios. including discussions on maternal health disparities and how to best model those conversations. We have done a video at one of our pilot hospital sites, and this video has already been used for educational purposes in grand rounds in the clinic and hospital settings. And then for our patient advisory committee, this is made up of patients with lived experience who delivered at or near the pilot hospitals that we're working with, who either had preeclampsia or some other adverse health outcome. And we meet once a month, and it's really a safe space for these women and birthing people. It's pretty much, it serves as a sisterhood to really collaborate and listen and learn from each other. And they met with the pilot hospital leads, and the clinic champions to collaborate and truly enhance the importance of patient and community voices. And currently we have about 11 patients that serve on the committee, and they had their eyes and input on the education materials that you see because we really wanted something that resonated with the patients. We also had press releases where each hospital announced the initiative. And then, as I mentioned before, we have been out there at community events and fairs, as I mentioned, March of Dimes, faith-based organizations, and so on. So this is another example of patient education materials with the prior information in a patient-centered format that we have been providing to our pilot hospital systems on behalf of the March of Dimes, along with the information sheet and the poster that you just saw. So we created this one specific to the campaign, with which the patients on the patient advisory committee weighed in on as well. So the original preeclampsia risk screening tool was created in collaboration between the United States Preventive Services Task Force, the American College of OBGYN, and the Society for Maternal Fetal Medicine. And some hospitals have even built this into their EPIC. So the tool released by the task force can be confusing, which is why I worked with the patients on the patient advisory committee to create the Should I Do Aspirin questions, which are written by and for patients. And you can find all of these patient education materials on our website at cmqcc.org, along with patient stories that I encourage you to read. So these are some pictures of some site visits that my former clinical lead and I, we drove around California. We flew to our different sites and visited with the teams that we were working with. And as you can see here in the picture with the blood pressure machine, we have our patient education materials there. So it's really cool because, you could be getting your blood pressure checked, and then everybody has a cell phone, which is almost always in their hand. So you can easily just scan that QR code, which gives you more information about preeclampsia and low-dose aspirin. And then to the far right, one of our pilot hospitals even put our poster in an elevator for all to see. So not just patients and birthing people. So it could be a grandfather or an aunt who might see this. So we are really spreading the word. And as I mentioned earlier, education truly is power. Okay, so for our cohort 2, we will be sending out invitation letters to invite select hospitals to participate in the expanded LDA pilot. Recruit a risk stratified by preeclampsia and preterm birth rates, high volume delivery sample of hospitals and affiliated clinics across California regions. We will continue to shape clinic to clinic QI, planning and implementation, and continue to have these monthly QI collaborative meetings, continue to provide updates on our patient and provider education tools, continue to have that community engagement. I'll also be putting together another patient advisory committee with patients that deliver at or near the new cohort of hospitals that we will be working with, and much, much more. So to support the scale up and expansion of the LDA campaign throughout California, we have done some webinars. We had a community webinar last year in June, where you see here, Jessica Wade was one of our speakers. And we decided to launch the Low Dose Aspirin webinar series in December of last year. So the first of 5 webinars was titled Discussing Risk Respectfully, and the second was titled Preventing Preterm Birth and Preeclampsia, How Can Pharmacists Help? So we will be having our third webinar focusing on the importance of doulas in the next few months. And the remainder of these series will be on the following topics: clinical, patient, and we'll have another community webinar. So webinars are open to anyone who is interested in the campaign and promoted on our CMQCC website, social media pages, and invitations will be sent to all registered MDC users. So I just wanted to talk about this briefly. This is a really big win for us. This sign was placed in a large healthcare provider office, which specifically called out aspirin as a product that may cause birth defects. So if you're a woman or a birthing person who sees this sign, you're absolutely not going to want to take low dose aspirin. And so I've been having multiple conversations with some of the team members at this office, and they consulted with their national quality, pharmacy, and legal department, and they'll be working with the national facilities to update the signage and replace aspirin with a different medication. So this approach will eliminate the previous conflicting message and still allow them to comply with Prop 65. So this is truly a big win, and we are making progress. So I wanted the amazing women birthing people on our patient advisory committee to express why they wanted to be on the committee. And I thought it would be important to share some of these messages with you. So I'll just read a few of them. One said, I want to help spread awareness to moms with risk factors of preeclampsia so they get the greatest prenatal care, deliver safely, and make it home. It should not be a death sentence for mom or baby. I am excited to contribute to the research and knowledge that will change the experiences and mortality rate of pregnant African Americans. And then lastly, to encourage, inspire, and educate the African American birthing community. I am not a medical professional, but I am a living testament to a broken system. So now I'd like to talk briefly about the low dose aspirin tools in our maternal data center. So 5 new measures on preeclampsia and preterm birth were built into the maternal data center to support hospitals' work on this LDA initiative. And the measures are LDA usage among those at risk of preeclampsia, preeclampsia among those at risk for preeclampsia, preeclampsia rate, preterm birth among those at risk for preeclampsia, and then preterm preeclampsia rate. So once hospitals uploaded their monthly patient discharge data, all these measures would be auto-calculated in the MDC, except for the first measure, which requires supplemental data submission. So using information available in the hospital EHR system, hospital staff would confirm if the patients at risk for preeclampsia were prescribed aspirin, and if so, how long they took it during the course of their pregnancy. Additionally, all of these measures were able to be broken down by race and ethnicity, payer group, delivery method, gestational age, and outpatient prenatal care group to find potential discrepancies in LDA usage within the patient population. And defining prenatal care groups was also a new implementation in the MDC to support the collaboration between hospital sites and their outpatient clinics. And as appropriate LDA use begins in that prenatal care setting, it was important for hospitals to be able to identify which outpatient clinics their patients were coming from. So from hospital to home, this is really important because preeclampsia can occur in the postpartum period. So we need to think about and talk about postpartum follow-up. This is an important slide. So this bar chart is looking at pregnancy-related deaths by cause and timing to death in California. So looking at the left-hand side, these are the most common causes of perinatal death. So we have cardiovascular disease, hemorrhage, sepsis or infection, hypertensive disorders of pregnancy, thrombotic pulmonary embolism. So looking at the hypertensive disorders of pregnancy line, you can see it is one of the top causes of maternal deaths. Only 8% happens during pregnancy, but the vast majority is happening in the first month or two after pregnancy. So it is essential that we think and talk about the importance of postpartum follow-up. So when we're thinking about hospital discharge and follow-up, we want to make sure that patients are getting blood pressure checks. Some hospitals actually give blood pressure cuffs at the time of hospital discharge to patients who have any of these hypertensive spectrum conditions to make sure that they are not getting worse when they go home. So there are walk-in blood pressure locations at clinics and local pharmacies, and some of the cuffs are Bluetooth enabled so that patients can be monitored remotely or nurses can do outreach calls. Understanding the signs and symptoms is crucial. This is hard because many postpartum patients have these symptoms: headaches, blurry vision, swelling, shortness of breath, and they are supposed, if these symptoms actually persist, then patients need to be checked upon, and they need to be able to get in touch with one of their physicians. And then, early appointment. So if someone has had preeclampsia, they are supposed to be seen for follow-up within 72 hours. And what's really cool is that follow-up can be remote. And then lastly, transition to PCP, back to their primary care provider, is really, really important. And so there has to be a good transition because increased risk of chronic hypertension and stroke over lifetime, double rate of cardiovascular disease compared to women with no preeclampsia. There could also be medication changes. So it's really, really important that there is an easy transition back to their PCP. So just some closing statements. The work continues. We should all be engaging with communities, and collaboration with hospitals and clinics really is important. We want to provide support to community organizations to do this. And through the clinic-to-clinic and community-to-community networks, we can help inform the state and nationwide scale-up of the project. And there is a disconnect with hospitals and clinics, and community organizations matter, and patient voices are just so important. There's an opportunity for the interconnectedness of teams because these kinds of interventions need to engage community, which can enhance a collaborative partnership and help prevent preeclampsia and preterm births, especially among birthing people of color. So continue to do hospital and clinic evaluation and garner lessons learned in order to scale up. And we've even created FAQ sheets for providers, community-based organizations, and patients. And then lastly, we are in the process of developing an effective piloted low-dose aspirin implementation guide for community and hospital providers, community advocates, with efficient data collection options. And then lastly, some other next steps. We will continue to grow our social media LDA messaging, center patients and their experiences with LDA during pregnancy, participate in community events and health fairs, track and analyze data, and create NICU family LDA patient education materials. So what you can do: learn more yourself and listen. We can't just take this implicit bias training and check it off and say we did it. We need to acknowledge our biases and we need to check them at the door. Educate patients, family, friends about low-dose aspirin and about preeclampsia symptoms. And some key messages you can share with patients when they ask about low-dose aspirin include: LDA is very safe to take. It's safely used in all races and ages. LDA can make pregnancies last longer and keep moms and babies safe. And if taking LDA, it is important to take it daily. So our mission at CMQCC is to end preventable morbidity, mortality, and racial disparities in maternity care. We create tools, including scripts and education materials, and improve outcomes through data-driven quality improvement. So we all must listen with our hearts and minds and remember that the more different someone is from us, the harder we need to listen. Thank you.
Thank you, Dr. Duplessis. That was a great presentation. Great information.
Thank you.
If anyone has any questions, we now have time for a Q&A. I know Dr. Duplessis' staff has been in the chat answering some questions, but if you would like to take yourself off mute or type a question in the chat, we can address those now. One person, sorry, I don't know why it keeps doing that, but one person in the chat did put, oh, I have to scroll up. Can LDA start as soon as the client is pregnant, and for how long, and the postpartum period also?
So I can take a stab at that, or our clinical lead can. Sarah? Is she here?
I'm muted. Okay. Yes. So recommendation is to start between 12 and 16 weeks. What I will say as a clinician, sometimes it's really helpful to start the discussion before that time to make sure that we're kind of addressing questions, concerns before it's, that ideal start period, but 12 to 16 weeks is the recommendation, and then to continue all the way through birth. There was a question about using it in the postpartum period. The recommendation is to discontinue at birth. What I will say about postpartum preeclampsia, the risk is much lower for postpartum preeclampsia. So just making sure that, our patients and community know that that's still an ongoing risk after can be important.
Thank you, Sarah. Any other questions? Well, in the meantime, I do want to say, Dr. Plessis, I want to give a personal statement here, is that I was on low dose aspirin when I was pregnant. But I will say that I could have pregnancy brain, but I don't really recall my OBGYN explaining why I was on a low dose aspirin. I just remember them saying you need to take this because of risk factors, but didn't really go into what those risk factors were. So when I got home, I didn't take it because I didn't really understand why I was taking it. And it wasn't until I met with my midwife, and my midwife explained, they probably prescribed it because you're at high risk for blood pressure, et cetera, et cetera. And then, they had me stop it, I think like a month or so before I gave birth, I stopped it. But when I was in labor, I remember my blood pressure shot up to like 200 and something over 190. So I very easily could have stroked out, and that could have been fatal for me and my baby. So I just think from the clinician standpoint, explaining to your patients the reasons why they're taking a low dose aspirin and the implications of it, or any complications that can come from taking it, but just being very thorough about educating your patient on why they're taking this medication is very essential. Because for me, like I said, I almost didn't take it. It was only because of the education that was given to me by my midwife was why I was actually compliant with taking that medication. So education is very important for your patients.
I agree, Natasha. Thanks for sharing that. And also, I have a story for you all. So one of the patients on my patient advisory committee told me that her provider said she needed to be on low dose aspirin because she was Black and fat. And that's exactly what she said, right? And that's a problem. And so she said, well, I'm not taking this. There was no explanation behind that. And that was not discussing anything respectfully. And so what I did, and I always preface it by saying, I am not a clinician, okay? But these risk factors are not discussed. And so what I did was I hopped on a Zoom call with her. I had my 2-year-old daughter sitting right next to me, and we talked about these risk factors for about 30 minutes. And I went through all of the risk factors, the high risk factors and the moderate risk factors. And she had about 4 or 5 of those. And I really explained everything to her. And she felt comfortable with me. And I wasn't talking at her. I was just talking with her, right? And she ended up being on low dose aspirin. Now, she was fine. Her baby was fine. She actually ended up getting postpartum preeclampsia. Now, who knows what would have happened if I didn't have that conversation with her, So it is happening, and we truly do need to educate. We can't just, providers can't and clinicians just can't say, you need to be on this. It's not going to fly.
Well, I think that's a really good job, first of all, Lindsay, on that. But I
Yeah.
think it's a really good reason why making sure that we have a team-based approach. Sometimes, in my experience, our providers are some of the hardest to implement some of these things. So if we can get nurses, health educators, people who are already working with our patients and our community to have the opportunity to have these conversations, then there'll be an increased understanding of the purpose for why we are doing the low dose aspirin.
Okay. And someone had a question, is there a simple way to explain the mechanisms how low dose aspirin works?
Yes, I can explain how I usually explain it. This is not going to be kind of the only way to do so. But basically, the way I explain it to patients is we don't totally know why preeclampsia happens, but we think it has to do with stress and inflammation from the placenta. The placenta is a vascular organ, just like our heart, just like our blood vessels. And so what we found is that aspirin actually reduces that risk of inflammation in a way that can help reduce preeclampsia. So in the same way that we use aspirin to help with our heart, right? We might have an older family member who takes aspirin daily for their heart health. We can take aspirin daily for our placental health, which is going to help with maternal health and with fetal health. So that's the way I try to explain it. It's still a little bit technical, but it's really looking to kind of support the vascular kind of blood vessel components of the placenta.
Thank you for explaining that, Sarah. Any other questions, comments? Yeah, it sounds like great guidance on the importance of patients understanding the why of LDA, for sure, definitely, because that will play a factor in, like I said, compliance.
Mm-hmm.
A huge factor, actually, is the understanding. Well, okay, if we don't have any other questions or any other comments, I will close the meeting out and let everyone get on about their day. And just thank you once again, Dr. Plessis. We want to thank everyone for coming and participating and sharing your questions. Thank you. And I'm sorry about that thing going off in the background. We have literally no idea why it's doing that.
No problem. Thank you. No, thanks so much for having me, Jessica and Natasha. And thank you so much, Sarah and Brittany, for being on here and helping out.
All right.
Thanks so
Take
much.
care, everyone. Thank you. Bye.
Bye-bye.
Oh, Marjorie, are you still here? Did you have a question or you just